about mental health, neighbourhoods and dashboards again. Thank you, John.
Hello, can everybody hear me? Good, right, thank you for coming. Thank you for taking the time to watch my presentation. My name's John O'Neill. I work for the Midlands and Lancashire Commissioning Support Unit, and I'm embedded at Birmingham and Solihull Clinical Commissioning Group. And something that's quite rare for analysts is to just work in mental health data, and I primarily do just work in mental health data. So this short presentation, I've only got 10 minutes, I'm going to rattle through it, is about the work I've done to evaluate the mental health, neighbourhood mental health teams that have deployed in Birmingham and Solihull. So I'm going to give a very brief background about what neighbourhood mental health teams are in this context, and then look at the reporting solution that I've developed so far. It's a work in progress, but the bits that are done, so they're worth looking at. And I've, as requested, I've all the logos. Okay, so this is us. Give us business. Okay. What is neighbourhood mental health teams in this context? A change programme was enacted across Birmingham, which was called the Mental Health Community Transformation Programme, and part of that was the mobilisation of neighbourhood mental health teams, which were novel in the way that they were deployed. They were deployed and are deployed in general practice, so they're in primary care, which is different to the previous model where they were held in secondary care. And the idea that deploying them in primary care would mean that they would fulfil these 4-step aims, which are swift access, multi-agency, reduce inequality, and remove barriers. So when I looked and worked with the management of these teams to start to evaluate the work, we tried to shape something that was around these 4 steps, broadly speaking. So the reporting solution that I've developed pulls information from the MHSDS. So it means it is used operationally, but the MHSDS is designed for secondary uses. So there is a lag of about 6 weeks before management get this information. But the reason we chose to use the MHSDS is because it's system-wide. And it means we've got people from multiple organisations contributing to this programme. So they all feed into the MHSDS. And we had tried in the pilot to use GP systems and then extract the information from GP systems, which was a nightmare. So I pushed really hard not to do that again, and we've ended up using the MHSDS. Hang on. Oh, also, yes. So the wrangling I do in SQL, it's visualised in Tableau, and the platform that it's accessed on by the primary care teams is Aristotle, which is the CSU's wonderful data viz platform. And now I'm going to attempt to switch to the live system, which could end in disaster. So here we go. This is the viz. This is how it is at the moment. So first of all, there's an activity overview slide. Then we look at the proportion of prevalence accessing, and I'll explain that. Then we look at patient characteristics and whether the patient characteristics in the service represent what is in the general population. And then we have a look at assessment tools. So that's a way of quantifying patient outcomes. And it's a strategic direction of travel that mental health patients have assessment tools used. So we will look at dialogue. So the first thing is just give you a brief feel for what the activity has been. And the service has been mobilised for about 2 years now. How long? I don't know how I'm doing for time. But basically...
Sorry to interrupt. I think you might need to show a different window if you're trying to do the live demo. I think you're still on your slides. Just to...
hang on a minute.
Sorry to interrupt you there.
You can't see that. Hang on. Shall I change the way I'm... Maybe I'm not... Change my display settings. Okay, it's extending. I'm going to duplicate. Is that what I need to do? So, I'll speed up. 16,000 people have had at least one contact in the service. The waits are relatively short, 21 days, but there's a significant proportion that are seen within 3 days. It's young, working age adults predominantly that come into the service for anxiety or depression predominantly. And the next thing I wanted to look at. So, the first bit of equalities work really is to look at the proportion of prevalence accessing. So this is about geographic inequality. And the prevalence rates are here. And what I do is apply these to the population, and this is the working out here. So if you look at Erdington, which is the hotspot for access in Birmingham, you can see that the population is 72,000. If you apply the prevalence rates of any mental disorder and common mental disorder, you get a prevalent population of 14,000, which means the patients accessing is 1,300, so you've got 9.5% of the prevalent population accessing. This allows you to see all the different areas in a comparable way because they've all got different population volumes. And it allows you to see inequalities of access. Now, actually, compared to other services, accesses such as talking therapies, access is a bit more equitable in this service, but there are still hot spots and cold spots. For example, Erdington is an access hotspot, Sutton is an access cold spot. Now, sometimes prevalence, you do have to sort of add a bit of your own understanding and context to it because it's local authority wide, often the prevalence, and where IMD is higher, you get higher prevalence. So you have to sort of bring that understanding when you do interpret the data. If the practitioners can then go in and drill down and say, okay, in the north, we've got high spots in Erdington, but what about the wards of Erdington? And you can go in and see that there are some parts of Erdington like Gravelly Hill and Stockland Green and Castle Vale that have higher access, and in Sutton Coldfield, although it is generally low, Sutton Vesey has slightly higher access. And also it will drill it down by IMD, so in the north locality, as we call it in BSOL, most access does come from those people who live in the most deprived areas. Another part I have looked at is characteristic representation. So this looks at over or under representation of a patient characteristic in the service compared to that characteristic in the local population. The easiest way, and the population data we've got is up to date because we're using NHS Spine population data. The easiest way to explain this is to look at females. If it's positive, it's overrepresentation, the way I've plotted it. If it's negative, it's underrepresentation. So females are 25% overrepresented in the service, which is common in mental health services. And the working out for that is the characteristic of females in the neighbourhood mental health teams is 60%. The characteristic in the central locality population in Birmingham is 48%. And so that leads to 124% overrepresentation. I then subtract one, so you get a positive figure if it's overrepresentation, a negative figure if it's underrepresentation, just so it plots nicely on charts. And users can drill down to different areas, and then if we look at a slightly more, I can say interesting, but that's not the way to look at it, but with more data points, we look at age, instantly we can see that, again, it's working age adults, as we saw in the activity, that are overrepresented in service, especially the younger adults. So this is essentially where the demand is in terms of age. How much time have I got left? Okay, a couple of minutes. And then the same thing for IMD. This performs as you would expect, where higher IMDs are more represented in the service and less deprived areas are less represented in the service. Now, that's not necessarily a bad thing because, as I said, prevalence for mental health conditions often coalesces in areas that are more deprived. So this might be sort of what you're expecting to see. Ethnic grouping, and what I'm going to do is widen this out and look at all localities. Now you can see instantly the data's massively skewed because we've got a huge proportion here, not huge, but 20% of the patients don't have their ethnicity coded. The reason I leave this on the chart is to sort of shame the service into improving their ethnicity coding. That hasn't quite happened yet. Other charts that I do this for, I impute the data, and we know the ethnicities from other healthcare areas that the patients has accessed. I haven't done that here. But what you tend to see, so there is a slight, well, white ethnicities are in balance with the population. Now, often what you see with other mental health areas is that the white population is overrepresented. So this service has sort of taken steps to combat that, and they've got representation of white population in balance with the population, sorry. But other ethnicities are still underrepresented. So Asian British is underrepresented. Black African, Black Caribbean is underrepresented compared to the local population. That's really common in mental health services and maybe other services. Now, if you want to go beyond the ethnic group and drill into the more detailed descriptions, again, you do get an interesting story, and again, the data's massively skewed there by the not knowns. So the example to look at is within the black ethnicities, which are underrepresented, Caribbean ethnicities tend to be slightly overrepresented or in balance with the population. So it's not a one-size-fits-all when you're looking at your ethnic groups, is the thing to pull from that. And I'm going to move on. The next thing is assessment tools, right? So this looks at how many assessment tools have been deployed, and as you can see, in 99% of cases across all the locality teams for neighbourhood mental health teams, assessment tools haven't been deployed, basically. So this is an area that's in its infancy for this team, but this allows them to see that and to sort of make progress. So what I'm going to do is show you dialogue, but I'm not going to show it you for this service because they have hardly deployed any dialogues. I'm going to show you a dialogue dashboard just to give you an example of the sort of data we can get from assessment tools once they are properly deployed. And this is dialogue tools for children and young people in Birmingham and Solihull. And this allows you to split a patient's outcomes into all of these areas here. So there's about 10 different life areas: job situation, mental health, friendships, leisure activities, partner, family, personal safety, physical health, accommodation. And then there's 3 treatment areas, which is medication, mental health professional, and practical help. Now, for children and young people, we haven't got loads of deployment either for dialogue, but we've got 27 before and after. They're essentially questionnaires, and you need before and after in order to see a distance travelled. We've got 27 before and afters, and for these 0 to 25-year-olds it is, that have been through the dialogue assessments, this is the percent of dissatisfaction that the percent that dissatisfaction declines, basically. So it's a bit counterintuitive, but what you want to see is that the proportion of patients who are expressing dissatisfaction in a life area, you want to see that decline or disappear completely by the time they finish treatment. And this shows how much dissatisfaction has declined in each of these areas. So you can see the areas where it's declined the most is job situation, it's declined, and also in the mental health area, dissatisfaction has declined. But it also allows you to see, this is all the areas where explicit dissatisfaction was expressed on the first score. So it kind of allows you to think, well, we know where these people are expressing their dissatisfaction and where their anxieties and maybe where the problems are coming from. So maybe we can start to adapt treatment to address these specific areas, because we know these are the areas that are causing the patients the most problems. As I say, this is still in its infancy, really. And then I'm going to skip back
Sorry to cut in again, John. I think we're
Yeah.
running out of time in terms
Yeah,
of the schedule.
I
If-
am coming
If there's
to the
anything
end,
else, be
believe it or
very quick. Otherwise, we might have time for one or two questions.
You're right. And so basically, that's the end. So further developments. It's not finished. When I get time, a key part of the neighbourhood mental health teams was to reduce patient flows in other areas and to treat them in primary care first and, early intervention. And so we need to assess that. We need to look at all the data in different healthcare areas to see if that's happening. And then also to look at other assessment tools and then also do some waiting time inequality analysis. That's yet to do. Right, I think I've done it in 10 minutes. Any questions?
Thank you very much, John. Yeah, I know we're cutting slightly into lunch, but if there is any one question that's jumping out, Tom, going to go.
Perhaps John could just hop on my laptop and reply on them quickly afterwards. So the one that's got the most upvotes is, I know you've had issues accessing data from practices, but how confident are you about the prevalence figures? Fingertips figures tend to be accurate, but not timely.
Well, it's fingertips prevalence data that I've used. So.
Okay. So, there you go.
Okay, we got one from the room. I'll run down. I think we'll have to call it after this. I do have a public service announcement to make just after.
I thought the breakdown with characteristics was interesting, but have you looked to do anything about intersectionality, or do the numbers get too small?
To do anything about what, sorry?
Intersectionality, so looking at how it varies by ethnicity and age, for example, or ethnicity and IMD.
Yeah, that's the next step on, really. In an ideal world, yes, we want to get to that point, but I haven't yet got to that point. Yeah, but there's certainly intersectionality across not just ethnicities, but other dimensions of analysis. So we know that you get, if non-white people live in less deprived areas, some more affluent areas, they're less likely to access mental health services or to need mental health services. But it's that where ethnic minority, high populations, and IMD intersect. That's where you get really high demand.
Brilliant. Thank you very much.